We are so fortunate to have Dr. Anthony DeMaria with us today. He graduated from the New Jersey College of Medicine in 1968 and completed his cardiology fellowship at University of California, Davis. In 1981, he became the chief of cardiology at the University of Kentucky in Lexington. And he was there until 1992 when he became the professor of medicine and chief of cardiology at the University of California, San Diego. In 2004, he founded the UCSD Sulpizio Family Cardiovascular Center. I'm sorry, I even practiced that. But his field of specialization is cardiac imaging techniques. And this is unbelievable. He's authored or co-authored over 530 articles for medical journals. He's listed in the best doctors in America and also listed by Good Housekeeping as one of the best heart doctors in America. So please join me in welcoming Dr. DeMaria.
Thank you very much for that very generous introduction. I'll try to catch us up on time as much as I can. This will be a shift from your last lecture, and I'm going to focus primarily on cardiovascular disease and the influence or interaction of sleep-disordered breathing. And if you will allow me, I'll use the term sleep-disordered breathing to encompass both obstructive sleep apnea and central sleep apnea. And we can talk a little bit more about that in a moment. But thinking that you may not be so familiar with heart disease, I thought maybe it would be worthwhile to make some points about heart disease. Estimated at the moment that 81 million American adults have some form of cardiovascular disease, that's heart and vessels. The lifetime risk for cardiovascular disease is 2 in 3 for men and 1 in 2 for women at age 40. So you all look much younger than 40 out there, but in case any of you may be 41, you've encountered a little bit of a risk already, as you can see. And cardiovascular disease caused 35% of all the deaths in 2006. And if you take any mention of cardiovascular disease, it accounts for 56% of all deaths. Now let me remind you that when God made the heart, she screwed up majorly. And that always gets me a little applause. But in fact, all of the blood in the body with its good oxygen nutrients goes through the chambers of the heart. But the heart muscle itself can't use that blood and oxygen. So ironically, the blood has to be pumped out of the heart, and then it comes back in again through these special arteries on the outside of the heart called the coronary arteries. And so that's a very inefficient way to provide nutrients for heart muscle. And as I say, if I was making the heart, I wouldn't have made it that way, but I don't have a shot at that. But anyway, these arteries are very, very predisposed to get plaques, obstruction, and blockages, and that's the most common form of heart disease. There are, of course, a number of other aspects of the heart. There's the heart valves, for instance, that keep blood going forward, and they can become diseased. And then there's the great vessels that the heart's attached to, so you can have high blood pressure in either the lungs or in the systemic circulation, hypertension as we know it, or have blockages in those arteries that cause strokes. And then there's an electrical system that fires the heart muscle. It's like spark plugs for the motor of an automobile, and you can get shorts in that electrical system, and that's arrhythmias. And so there's a wide variety of things that can go wrong with the heart, and my message to you will be that they're particularly common in the setting of sleep-disordered breathing. And these are plaques. You can see here's a normal vessel wall, but down here, that's a plaque. It's got cholesterol, fats, it's got inflammatory cells, and as it gets bigger and bigger, it encroaches upon the lumen and obstructs blood flow, and that's the cause of heart attacks, or if it's the blood vessels to the brain, it causes strokes. And people say, why do you get heart disease? Why do you get this atherosclerosis? Well, the short answer is we don't know exactly, but we know that there are risk modifiers, risk factors that predispose us. Now, some of them are modifiable, some of them are not. The last time I checked, you can't pick your parents. Your gender's more or less fixed for life. There's no way to get younger that I've figured out anyway. So that age and family history and gender are risk factors that we can't do anything about. But there's a lot of risk factors that we can do things about, like our types of cholesterol, blood lipids. We can do things about diet, smoking, excess alcohol, physical inactivity, or obesity. And in our society, diet and obesity are becoming progressively more important. And as an of that, you see in this article in this famous scientific journal, Newsweek, 15% of U.S. children are overweight, and 2/3 of them have more than one component of something called a metabolic syndrome, which predisposes to heart disease. Now, I bring this up because the metabolic syndrome enormously predisposes to sleep-disordered breathing as well, obstructive sleep apnea. So you can see already there are links that bring these two together. And why are these two? Well, you know, it used to be that small was actually small. Now small is large, and large is giant size. And you have these things, you can't read this, but actually this is, it's a Hardee's Monster hamburger. It's got 2 1/3 pound slabs of Angus beef, 4 strips of bacon, 3 slices of cheese, mayonnaise on a buttered sesame seed roll. This one little beauty has 1,500 calories. Okay? And our kids are eating a ton of them. Not me, of course, but someone else. Look at this, a fried Twinkie. Now, my God, what could be worse than a Twinkie except if you fried it? So, you know, this is my favorite. This was taken at a heart meeting, okay? It was at the intermission of the heart meeting, and there's nobody. None of these cardiologists are taking the stairs. They're all taking the escalator. So that, you know, here's, unfortunately, here's what passes for modern day sports. You can see this young man sitting at a computer monitor with a game, and he's got a little pedal there. So in fact, we've done this to ourselves, you know, as we have had an industrialized society. We've done this to ourselves, and we've come from primates to upstanding humans, but we're deteriorating a bit, and unfortunately it's causing a lot of cardiovascular disease. Now, given the prevalence, given the enormous prevalence of cardiovascular disease, what do we know about sleep apnea? Well, it's actually surprisingly common. 1 in 5 Americans has some kind of evidence of disordered sleep breathing. And it's moderate, actually, in 1 in 15. 85% of these cases currently are believed to be undiagnosed, so that you're a particularly aware group and the physicians you're hearing from are particularly aware. But unfortunately, this is still a somewhat unrecognized problem in our society. And interestingly enough, one of the primary manifestations of sleep-disordered breathing is sleepiness, somnolence. So that if you're not sleeping at night, it's not unusual to fall asleep during the day. However, an exception to that is in conjunction with heart failure. Patients who have heart failure don't seem to be sleepy. So that if someone comes in with heart failure and their physician says, do you find that you nod off during the day, they're likely to say no, even if they have rather advanced sleep-disordered breathing. Now, what makes this challenging for cardiologists is that the risk factors that I've shared with you for heart disease are also the risk factors for sleep-disordered breathing. And you see them listed here: male sex, age, overweightness or obesity, particularly central body fat distribution leading to what we call the metabolic syndrome, alcohol, smoking, and lack of exercise. So it's not surprising, it's almost predictable that people who are likely to develop heart disease, cardiovascular disease, are also likely to develop sleep-disordered breathing. So what are the links? What are the interactions? Well, in fact, there's a good number of them. And I don't think I'm going to have enough time to discuss all of these, or not that you would let me anyway. But in fact, hypertension, high blood pressure, is closely linked to sleep-disordered breathing. Heart failure, which is the largest growing category of heart disease, whether you have a heart attack or whether your heart muscle becomes inflamed or whether your heart valves leak, whatever, excuse me, the final common pathway is heart failure, where the heart just can't seem to pump enough blood to the body to meet the demands. We'll talk a little bit about arrhythmias. I heard a little bit about that earlier. Coronary artery disease, stroke, which for many of us is a more worrisome condition than even a heart attack because of the disability. And I'll just point out pulmonary hypertension, but this is relatively uncommon, and I don't plan to say anything about that. Now, there's recently, just to show you how important this is, there's recently been a consensus document that was published jointly by the American Heart Association, American College of Cardiology, with the collaboration of the National Heart, Lung, and Blood Institute, the NIH in Washington, attesting to the importance of sleep-disordered breathing in developing heart disease, in heart disease developing sleep-disordered breathing. Now, central sleep apnea is simple to think of. The nerve transmission from the brain, from the central nervous system out to initiate a breath just doesn't happen. And there's lots of neuromuscular causes for that, and they will be covered by others. But in fact, this also happens particularly in advanced heart failure. When I was an intern some years ago, we used to call this Cheyne-Stokes respiration. And Cheyne-Stokes respiration would be very, very irregular respiration. What would happen is that there would be no signal to breathe because of the heart failure's influence on the central nervous system. So there'd be apnea, the lack of breathing. During that time, the oxygen level would go down, the CO2 level, carbon dioxide level, would go up, and both of these things would suddenly crash upon the brain and say, you've got to breathe. And then all of a sudden, the patient would start breathing again, have an arousal, and breathe very, very rapidly and somewhat deeply until the oxygen and CO2 were balanced, at which time the cycle would start all over again. So that's central sleep apnea. Much, much more commonly, as the last speaker said, is obstructive sleep apnea. And there the airway, which in normal individuals is wide open to allow the transmission of respired gases, inhale and exhale, in patients become blocked as the tongue and palate actually collapse and eliminate the airway. And so the same cycle happens. There'll be a gradual obstruction of the airway, and then even though the patient is trying to breathe, the muscles are trying to expand to enter air, the diaphragm's lowering, there's no air that can get through, and this will go on for a while. The O2 goes down, the carbon dioxide goes up. All of a sudden the brain says you're going to die if you don't take a breath, and there's this enormous arousal, and the patient begins to breathe very vigorously until things are corrected, at which time the cycle starts again. So obstructive sleep apnea is very common, and obviously, as you heard from the last lecture, one of the ways to treat this is CPAP, continuous positive airway pressure, which is airway pressure delivered to the nose or mouth that in fact keeps the airway open, or for central sleep apnea actually delivers a breath to the patient during the course of apnea. Now, it's relatively easy to understand what a stress an apneic event can be for the body. Now, on the left, we have a normal condition with the airway, upper airway open. On the right, when the upper airway is occluded. And what you can see is with the occlusion of the airway, there's a marked negativity of pressure as the lungs are trying to expand, but no air can come in to fill them. And so that negative intrathoracic pressure does two things. It enlarges the right ventricle to the impairment of the left ventricle, which pumps blood to the rest of the body. It causes an increase in the wall tension of the left ventricle, so it puts more stress on that muscle, and it constricts the pulmonary vasculature, so the blood pressure goes up in the pulmonary arteries as well. Very unnatural, very detrimental situation. So what you have is during these episodes you develop hypoxemia, low oxygen, hypercapnia, high CO2, and you get an increase in negative intrathoracic pressure, which results in these arousals. And the arousals are, it's like a jolt of adrenaline. Imagine yourself in bed, and every couple of minutes, depending upon how often these cycles occur, every so often somebody just slammed a syringe full of adrenaline into your body. And that's kind of what's happening. You get this enormous surge, your heart beats rapidly and forcefully. It's the fight or flight reaction until things quiet down. So you could imagine if that happened frequently enough, that would cause enormous damage, and it does. What happens, you get sympathetic activation, you change metabolic regulation because of that, you engender dysfunction of the lining of blood vessels, you cause systemic inflammation, and an increase in the tendency for blood clots to form. So in fact, it's not surprising that patients with sleep-disordered breathing have hypertension, heart failure, arrhythmias, kidney disease, strokes, and heart attacks, and in fact can have sudden death. It's clear that this should happen. And as we said, there is a modality of treatment, and we will discuss this as we go on. Of course, we'll first talk about the problem, and then what evidence do we have that treating it can be of benefit. And this is the treatment. This happens to be continuous positive airway pressure, but devices like this, a small motorized device that actually delivers gas to the airway, can be used for both central and obstructive sleep apnea, obstructive being much more common. So let's talk about hypertension first. Now, you're not going to be tested on this, so don't be frightened by these slides. But if you look at this, what we're plotting here is the percent of patients that have hypertension. And in the open bars are people who have obstructive sleep apnea. They have an apnea-hypopnea index of at least 5 episodes. And then in the hatched bars, less severe patients who snore but don't have 5, and then normals in black, okay? So whether you talk about body weight, whether you talk about gender, male or female, whether you talk about age above or below 45, you can see that if you have sleep-disordered breathing with an apnea-hypopnea index of only 5, that in fact your index of hypertension, your risk of hypertension, is nearly 40%, way, way more than normal individuals. So that it almost goes without saying that if you have significant sleep disordered breathing, an apnea-hypopnea index of, let's say, 10 or 15 episodes, then in fact your chances of having high blood pressure are well over 50%. So what do we know about high blood pressure and sleep disordered breathing? Well, it's likely caused by this systemic sympathetic stimulation, these arousal episodes, which result in the circulation of vasoconstrictor compounds. Sleep disordered breathing can often precede hypertension, and in fact, depending upon the level of sleep disordered breathing you have, as I said, approximately 50% of patients can have high blood pressure. Looking at it the other way around, about 30% of all people who have high blood pressure have sleep disordered breathing. What's really important about this is that treating the sleep disordered breathing is often more effective than giving antihypertensive drugs. I don't know how many of you out there have high blood pressure. You go to your doctor and your doctor gives you drugs and they work incredibly well. You know, it's one of the real achievements in medicine that we do so well with hypertension. But, in fact, if the hypertension is related to sleep disordered breathing, you're much better off with CPAP or BiPAP or some other form of treatment. An important group of patients, so-called refractory hypertension. Okay, refractory hypertension is high blood pressure that can't be normalized using even 3 antihypertensive drugs. So you get one drug and that doesn't work, you get a second medicine, that still doesn't do the job, you get a third medicine and your blood pressure is still high. There's a number of people who have refractory hypertension, and in those patients, studies indicate up to 80% of them have sleep disordered breathing, and one way to control the high blood pressure is to treat the sleep disordered breathing. In fact, these data are so well established that the Joint National Commission on hypertension, which is a national organization that makes recommendations. They make them every couple of years. The last one was their 7th. So JNC 7 recognizes the relationship. Now, what about if you treat it? Well, what's interesting is that if you look at all the studies that have been done, virtually all of them show an improvement with CPAP, with positive pressure. Virtually all of these studies in patients with hypertension. However, the magnitude of improvement is less than 5 millimeters of mercury, so it's not enormous. So what kind of take-home message could I give you? Well, in terms of how well that positive pressure works in hypertension, it works in almost everyone. The reductions in blood pressure tend to be modest, only about 5 millimeters of mercury. However, they seem to be related to the severity of both the hypertension and the sleep-disordered breathing. So in people who have advanced hypertension and who have more severe sleep-disordered breathing, then in fact the positive pressure has a much greater magnitude of effect. You do, of course, have to be compliant. And I bring that up because it wasn't clear that all the patients in that study were actually compliant. I mean, to say, do you use your mask? And oh yeah, I use my mask. I use it to keep the papers down on my desk. You know? I don't actually use it for sleep apnea. Interestingly enough, treating hypertension with blood pressure drugs doesn't seem to do very much good for the sleep apnea. So let's turn our attention to heart failure now. And again, the prevalence of sleep-disordered breathing in patients with congestive heart failure is rather dramatic. These are all individual studies that have been published in the medical literature. This is something called a meta-analysis. And you can see with an apnea-hypopnea index of 10 that in fact you're up around 50 to 70% of those patients. You found, let me say it another way, you found an apnea-hypopnea index of greater than 10 in some 50 to 70% of patients with heart failure. Of greater than 15, it was a lesser number, but still an extraordinary 50% of the patients with rather advanced sleep-disordered breathing. And in heart failure, you have a slightly greater increase in central sleep apnea, the so-called Cheyne-Stokes. More recent data, these are from 4 studies, have shown that in patients with congestive heart failure, the prevalence of sleep-disordered breathing, in one study was as high as 50%, in another 26%, and in this study 26%. So, you know, I think what we can say is that sleep-disordered breathing is very common in heart failure, and the more severe the heart failure, the more likely you are to have sleep-disordered breathing, and the more severe it is likely to be. Now, one of the interesting things about that is the interaction between sleep-disordered breathing and heart failure, because if you have heart failure, you retain fluid, you retain salt and water, and that fluid at first goes to the lungs and makes you short of breath, but then it goes into the lower extremities because of the force of gravity pulling the fluid down into the lower extremities. And so when you go to bed at night, what happens? Well, you're flat, gravity is not effective any longer, and so the fluid returns from the legs to the central circulation and all the way back to the neck. And what these very ingenious investigators showed in this particular study is that the greater the shift in fluid from the legs, the greater was the effect in reducing or increasing the circumference of the neck, actually, but therefore reducing the airway because you put fluid in the soft tissue. So whether it was obstructive sleep apnea or central sleep apnea, in fact, in patients with heart failure, when they laid down, the fluid left their legs, it went to their neck, and it compromised their airway and provoked sleep disordered breathing. And so you can see that there's a definite relationship. This is the change in fluid leaving the leg, with more fluid leaving the leg from left to right. And this is the increase in sleep disordered breathing measured as the apnea-hypopnea index, apnea being no breathing, hypopnea being infrequent breathing. And in fact, you can see whether it's obstructive in the open circles or central in the closed circles, the more fluid left the legs of these patients with heart failure at night, the greater the sleep disordered breathing was when it was measured. So a clear-cut physiological relationship. Now, how effective is CPAP in heart failure? Well, fortunately, it's pretty effective. Here, baseline in open bars, positive pressure CPAP in the solid bars. And you can see that in both conditions, when the patients laid down, the change in lower extremity fluid was the same. But in those patients who had CPAP, there was a lower apnea-hypopnea index, and there was a lesser increase in the neck circumference. So CPAP being very effective in those heart failure patients, so that you can say, well, what if you have heart failure in the setting of coronary artery disease, that atherosclerosis I showed you, and do you get a benefit, or stated another way, is there a risk if you have sleep disordered breathing? And in fact, there clearly is. In the blue lines, those are the normals, and then you get progressively worse till you get to an apnea-hypopnea index of 30 in yellow. And you can see that disease-free survival is clearly much worse. The worse your sleep disordered breathing gets, your mortality's increased. And ladies, you're somewhat protected from this unfairly, it seems to me, but nevertheless you are, although it's not clear why. But still, there is some. So the effect of heart failure therapy on sleep disordered breathing is really not much to speak of. Some of the studies have been done, but not all, have shown some benefit, probably because you get rid of fluid. And the benefit has come from virtually all modalities. The problem is that none of these studies were controlled. So let's just try to get to some take-home messages about heart failure and obstructive sleep apnea. The data are not all consistent. Most studies show a benefit of CPAP on heart failure and of heart failure treatment on sleep disordered breathing, but it's not 100%. In almost all the cases, blood pressure is reduced and the force of contraction of the left ventricle, that's called the left ventricular ejection fraction, is increased. So good things happen. There's a decrease in this sympathetic adrenaline type of tone. You get a change in the autonomic nervous system, which makes arrhythmias less common. And you get a reduced output of epinephrine in your urine, indicating there are less of these arousals. The issues are that these are all surrogate mechanisms, and so whether you prolong life and how much you prolong it remains to be identified. And in fact, there's a very important study that's about 3/4 of the way through in Europe called the HF, what's it? Say that. SERV-HF. Thank you. And that should give us the answer. However, there is some intriguing data from 2 studies that have been done in the last couple of years that have looked at heart failure mortality. And the first study showed a real trend toward reduced mortality, which is encouraging. The second trend showed a reduction in death and hospitalization for heart failure. So encouraging data. I think more data will come. These data look very, very important. Survival in the patients who excuse me, were without sleep disordered breathing was much higher than those patients who didn't get treated. The problem was that they weren't randomized, so there might have been something unique about the patients who didn't get treated. So let's go on and talk about a second problem, which is atrial fibrillation. Now, atrial fibrillation, the normal heart beats very rhythmically from top to bottom. There's an electrical impulse that travels down, and it's called sinus rhythm. But every so often, an arrhythmia will occur of the upper chambers of the heart called atrial fibrillation, where the heart beats very rapidly and very erratically. And that's a common arrhythmia in our society. It's even more common in patients with sleep-disordered breathing. So you can see in this study for patients over the age of 65, it was about 3 times the incidence of atrial fibrillation in the patients who had sleep-disordered breathing. Not only was there more atrial fibrillation, but the severity of the atrial fibrillation was worse. So as compared to controls, the percentage of patients who had paroxysmal atrial fibrillation, which comes and goes, or persistent atrial fibrillation, which is persistent, was proportionally greater. There are other arrhythmias besides atrial fibrillation, and that's shown in this study. And you can see, as compared to patients without any sleep-disordered breathing in the open bars, the patients in the shaded bars who had sleep-disordered breathing had more atrial fibrillation, more complex ventricular arrhythmias, more bigeminy where every other beat is an arrhythmia, and more quadrigeminy where every 4th beat is. So both arrhythmias of the atria and ventricles. So what about the value of CPAP in those patients? Well, at the moment, there just haven't been unequivocal studies done to prove that CPAP would be valuable in those patients. Makes all the sense in the world because of what I've showed you about what it does to pathophysiology, and we're very desirous of performing those studies now. But those randomized prospective data are not yet available to absolutely guarantee us that if we treat that the atrial fibrillation will go away. The preliminary data, though, is very encouraging. And the last discussion deals with stroke, and that's going to be a similar kind of a message, which is that sleep-disordered breathing predisposes to stroke. Here you see the probability of event-free survival dealing specifically with stroke or death. And in fact, as compared to controls, patients with sleep apnea syndrome had a much lesser likelihood of event-free survival. From this study taken from Circulation, you can see the percent of stroke cases if you had no sleep-disordered breathing, that is an apnea-hypopnea index of less than 5, then you are much better off. The likelihood of having a stroke with an apnea-hypopnea index of greater than 5 in this study was over 3 times as great and nearly 15%. So a very worrying event. Now, there are some confounders. There have been very few studies done before an initial stroke, so a lot of these have been done in patients who already had some evidence of disease. And it was uncertain whether sleep apnea characteristics were present beforehand. Nevertheless, there's, I think, compelling evidence that there's an association between sleep-disordered breathing and strokes, which are atherosclerosis of the carotid arteries to the brain and of the coronary arteries as well, here shown by this slide. So my time is up, and I've kind of delivered my message to you, I hope. The message really is that we've come to understand that there's this very close association between any kind of breathing abnormality, whether it be central or obstructive, and virtually all forms of heart disease, of the arteries, of the electrical system, and in fact, even of the small blood vessels that determine blood pressure. So that it's really keenly important that someone who has heart disease be evaluated, at least screened in a general sense, for possible sleep-disordered breathing, and that people with sleep-disordered breathing get carefully evaluated for heart disease. Thanks very much for your attention.
Are there any questions? Yes, Judith. She's coming with the microphone.
Could you briefly define cor pulmonale and what it means for this population?
Sure. Cor pulmonale is high blood pressure in the lungs. You know, most of us know about high blood pressure in the body overall. You go to the doctor, he slaps on a sphygmomanometer and takes your blood pressure. And we have normative values of blood pressure. And what I mean by that is you get 1,000 people and you see what the confidence limits are, and outside those confidence limits, then you say it's high blood pressure. But in fact, we know now that even within the common range of blood pressures, which don't seem to be elevated, that there's a risk. Now, it's harder to put a blood pressure cuff around the arteries in the lung. You know, most patients are reluctant to undergo a thoracotomy for that. So what we do instead is we do it by ultrasound, but it's essentially the same process, and it has some very significant morbidity. And there's many causes of cor pulmonale, many of them related to disease on the left side of the heart, but some primary pulmonary hypertension as well. Does that answer your question? Or?
Well, it's been implicated in post-polio.
Yeah, my understanding of that is that it's related in post-polio patients to a hypoxic stimulus that causes vasoconstriction of the pulmonary blood vessels and elevates the blood pressure. Pressure in the lungs is dependent upon the volume of blood and the tone of the arteries. So for any volume, the stronger the tone, then the higher the pressure. And hypoxia is clearly something that can induce increased pressure.
First of all, I wish my cardiologist had a sense of humor like you do. He's relatively humorless. The second thing is I am on Metoprolol, and also for the post-polio pain, tramadol. And I have probably the central nervous apnea because I have woke myself up with my heart pounding like mad, and obviously the adrenaline going through. Is there anything that I should watch out for? Because I found that he doesn't believe in post-polio syndrome. When I told him I had post-polio syndrome and I thought that was probably what the rapid heartbeat was all about, he went, to quote him. And so I just wanted to know, from your experience with the post-polio patients, is there any of the channel blockers and ACE and inhibitors and all these that I should be careful of? Because the Metoprolol seems to be controlling the rapid heartbeat.
Yeah, so let me issue a disclaimer. My experience with post-polio patients is not very extensive, so I wouldn't want you to get the idea that I actually knew what I was talking about. Having said that, reading the literature, it seems like you're being treated appropriately. The data in the literature that if in fact you've got a sleep syndrome related to the post-polio, then that definitely should be treated. And although we don't have unequivocal proof that it'll be effective, there's pretty good physiological rationale behind it. And then secondly, you ought to have some of the antiarrhythmic drugs. And classically what we do in cardiology, we start with the most benign drugs, of which metoprolol is one. So it's not likely to have side effects, and it's often effective. And then if problems persist, you work your way up. So I would say, in your case, and on any post-polio case, a dual-pronged approach is really important. And there's every reason to believe that the drugs will work as well in you as they do in other people. Yes, sir.
A medical professional recently told our group that untreated sleep-disordered breathing would cause damage to other parts of the body, such as the brainstem and the kidneys. Do you know if this is true?
Well, I wouldn't be at all surprised. You know, the same mechanisms take place. Adrenaline is no better for the kidneys than it is for the heart. It's the same thing. It's a vasoconstrictor. It predisposes to inflammation. So that we tend to think that if you have persistent sleep-disordered breathing, that it's likely that you'll have a systemic inflammatory state. And it can affect every organ in the body. I wouldn't stop at the organs you mentioned. I would say that what you're talking about during these arousals is a systemic event, and that it certainly has the potential to affect every organ in the body. Yes, sir.
Doctor, if you mentioned the studies are not conclusive on whether treating apnea benefits the heart disease patients, if a patient, at the end of the day, based on what you have now, if a patient has coronary artery disease, has CHF, congestive heart failure, and atrial fibrillation, with all those existing at once in a single patient, at the end of the day, would you recommend treating apnea or not?
Oh, yeah, no, I would recommend treating apnea for any one of those things.
Okay.
As a matter of fact, I think you probably ought to treat apnea if you don't have any of those things. I think if if you have the syndrome and you have an appropriate AHI, apnea-hypopnea index, and you can pick one, there's different literature. We tend to use 15.
Okay.
And you have sleepiness outside of heart failure, because in heart failure you don't. I think those patients ought to all be treated. Now, the heart failure makes it even more mandatory. Any of those things makes it even more mandatory. I think the problem is that there's so many patients with heart disease that we have that don't get screened for the sleep disordered breathing. It never gets detected and never gets treated. I think that's the bigger problem.
Thank you.